Hi everyone, good morning. Thanks for having me. I'm excited to present my research, my meta-analysis specifically that's been my baby for the last 2 years. But yes, it's finally done. I'm excited to talk about my journey in why we pursued this particular meta-analysis, and then going into the details of how it was conducted and the procedures and the processes that we used throughout. So the meta-analysis in general is looking at the work factors that impact quality of care and counterproductive work behaviours within care settings. And specifically, we looked at the care settings of residential aged care and hospital care. And I just wanted to also acknowledge the research team that and the sort of co-authors on the paper that we've written together and are going to send off for hopefully publication. So it was me, my supervisors, Dr. Kirsten Way, Dr. Teresa Scott, and Associate Professor April Wright. And we also had Esmita on the team as well, assisting with our data extraction from the meta-analysis. So thank you, Esmita. Okay, so the clicker is not working. Right. Sorry, just one sec. Thanks for your patience while we fix the clicker. Maybe I'll just use the keyboard. Okay, wonderful. Thanks, Sophie. All right, we're back in action. Okay, so the reason why we specifically wanted to look at the outcomes of quality of care and counterproductive work behaviours in residential aged care is because of the incidences of abuse and neglect that have been quite prevalent in the industry, as discussed quite heavily in the Royal Commission into Aged Care Quality and Safety. So I guess we noticed that there were particularly negative outcomes happening for frontline staff, and we're interested in why these outcomes are occurring. And these outcomes in particular are the high reports of abuse and neglect internationally within the industry of residential aged care. So this isn't something that's unique to Australia. This is something that these sort of commissions or investigations, independent investigations have happened in countries like the UK, in Canada, and research on how prevalent this has been has ranged from 6% to 82% internationally. So it's quite a high number. At the same time, the privatisation of the industry has increased in recent years. So in Australia in particular, 90% of residential aged care facilities are privatised, and this has been on the rise ever since the introduction of the Aged Care Act in 1999. So the Act essentially changed the way that the industry is run to be less government regulated and more, I guess, controlled by private providers. And the idea was that, with a lack of regulation and more competition and more marketisation, there would be a diversity of options for customers, for clients. There would be an improvement in the care provided through competition, through market, market competition just in general, and that this would hopefully increase the number of services provided and increase the quality of care within aged care. Unfortunately, that has not been the case, and instead, quality of care has on the decline in these industries and has now led to the Royal Commission. So in terms of our research aims, we wanted to kind of figure out, okay, well, is research design or is job design impacting these outcomes of poor quality care, abuse and neglect in residential aged care? Have there been, we know that job performance and in terms of care settings, that would be the quality of care provided, is impacted by job design, as well as counterproductive work behaviours such as abuse and neglect. So we wanted to research what are the effects of job demands, job resources and job strain within residential aged care or within care settings in general, and how are they affecting abuse and neglect and quality of care in those settings? And are these relationships, so is the strength of these relationships moderated by care settings? And so this particular question was asked because the prevalence of abuse and neglect is much higher in residential aged care compared to other care settings such as hospitals, for example, even though they're providing similar services and they have similarly skilled, or they both have nurses, they both have care workers, they both supposedly provide similar services. So why is incidences higher in residential aged care compared to other care settings such as hospitals? And so we argue that the reason for this could potentially be, using institutional theory, could potentially be institutional logics that are impacting these industries differently. So we argue that specific institutional logics could be creating a devaluation of specific roles within specific industries, and residential aged care being a salient example of where this could be happening. So we theorise that the effect of the market logic or the privatisation of residential aged care could be creating a transactional approach in the operations where the focus is on efficiency, it's on profit, it's on driving these sort of services in an efficient and cost-effective manner. And that these dominant logics could be also impacting the professional logics associated with type of care workers or the type of services that are provided in these industries. And so when I talk about institutional logics, what I mean is the guiding rules, social norms, and assumptions that facilitate the way that we interact within society and within specific organisational fields, just in general. So they're the norms that facilitate the way that we interact within these settings. And so we argue that there is a dominant market logic impacting, potentially impacting residential aged care, and this is supported by the high levels of privatisation within the industry that could potentially be focusing on a profit-driven business model, focusing on return on investment, and where value in this sort of setting is directed towards the core business operations as opposed to frontline staff or sort of staff working at the periphery of the core business operations. And what I mean by that is sort of decision makers, the people making decisions about finances and how the services are going to be provided in a way that provides profit or return on investment. And that in residential aged care, this market logic intersects with the negative biases against older adults. And what I mean by this is typically within residential aged care, the people who are clients of this type of service are usually older Australians in the final years of their life. So when older Australians enter residential aged care, they're usually there for a couple of years, unfortunately, before they pass away. So in terms of the value attributed to older Australians within residential aged care, the idea is they're not going to give back to economic society unless, under a market logic, their bodies are commodified. Additionally, workers working within residential aged care are seen as performing a role that is traditionally non-economic, such as caring for other people. So if residents were not in residential aged care, they would probably be at home being cared for by their family or a friend or someone who looks after them, and it's typically unpaid labour. So within this setting, a role that is perceived as an unpaid labour is being provided in exchange for money, but it's a traditionally non-economic role. And so under market logic, again, this idea of devaluation for the clients who are in residential aged care and the people who are providing care to those clients is seen as, I guess the investment in those services is not going to be very high, as under market logic, again, like I mentioned, the investment would be at the core business operations. and that this intersects with the professional logic. And in terms of professional logic, the professional logic of care workers, we suggest would probably be weak under a market logic, which means that the idea of a professional role that is legitimized, that is has a level of authority, has a level of backing in terms of a guild or a professional society, is not present for care workers, which potentially, from a job design perspective, would result in a mechanistic design of work, that has low autonomy, high demands, low job complexity, and then again, from an organisational perspective, low staffing, low investment of wages, not a lot of training, and so this results in high levels of unskilled labour and roles that could, potentially be easily replaceable to fit the business model of a highly privatised sort of facility. So the reason why I've been talking about these theoretical underpinnings is because it feeds into our broader conceptual model and the reasoning behind why we've decided to measure these particular variables. So in terms of our conceptual model, we are looking at the impact of high job demands, low job resources, and high job strain on poor quality care and counterproductive work behaviours in care settings. And we hypothesise that care setting will moderate this relationship because of the job characteristic differences within these settings that are potentially impacted, pending future research, by market and professional logics. We hypothesise that high job demands and low job resources and high job strain will be associated with lower quality of care in both these settings, and that high job demands and low job resources will be associated with higher counterproductive work behaviours in both these settings as well. And in terms of the moderating effects, we hypothesise that these relationships will be stronger in residential aged care compared to hospital care settings because of the theorising that I discussed before. So the approach that we took was a meta-analysis. We looked at the pooled effect sizes of the relationships between high job demands, low job resources, and job strain with the employee outcomes of quality of care, job performance, and counterproductive work behaviours. So we aggregated the pooled effect sizes and looked at the correlations between these IVs and DVs, and we compared the effect sizes across the two groups to see if there were differences in the strength of the relationship. Arguing that the effects are stronger in residential aged care, but this was potentially reflective of subordinate factors impacting job characteristics in these settings, such as maybe market logics or other institutional logics. We searched these 5 databases, Web of Science, Sonal, Scopus, ABI Inform, and Medline, to find our studies. The include and exclusion criteria were healthcare workers, so nurses, personal carers, other direct care workers. The intervention or the independent variables were job demands, job resources, including job strain. And in terms of the conceptualization of the job strain, it was this psychological impact, negative psychological impact on workers from their job. So this included things like burnout and job stress. The comparison groups were workers in residential aged care compared to workers in hospital settings, and the outcomes were quality of care and counterproductive behaviours. Additionally, since this was a meta-analysis and we were looking at quantitative data, we had to exclude a lot of papers that discuss these variables but potentially didn't have usable effect sizes. So we could only extract correlations, individual beta values and odds ratios, which really limited the amount of studies that we could include. So studies that looked at means and standard deviations only, or looked at beta weights, unfortunately we couldn't include in our analysis. But also we tried to include non-English papers where possible to limit the biases and just including English papers. So we used Google Translate where we could, if there was a table with interpretable variables there to extract. So you can see we conducted 2 searches, one in July and one in September, to account for any delays, as well as including any search alerts to account for any papers that come up between then and now. And so we started with 11 1,000 papers. And after our screening, we excluded quite a lot based on our inclusion criteria, and we ended up with a lovely 43 papers. We also used an assessment to assess the quality of the papers as well, using STROBE, which is strengthening the reporting of observational studies and epidemiology checklist. And we found that a majority of papers were of good quality, with one of low quality. We did not exclude that paper just because we didn't have a lot of data. I don't skip on the data. But yeah. So then we had to do our data synthesis and coding. So we coded all job demands together. We coded all job resources together. And we did also code all job strain types together, but we did sort of highlight that, you know, some of them were burnout measures, some of them were stress measures. In terms of quality of care, we only coded care that was person-centered. So a lot of studies did include, like, there were other meta-analyses that looked at quality of care outcomes, and they included things such as, you know, the physical care of residents, so bathing, feeding, etc. We decided not to include those as quality of care outcomes because it's possible to still complete those tasks but do them in a way that could be, you know, neglectful or abusive. So we coded quality of care, so as, you know, person-centered care, as opposed to the physical aspects of care. And then we also, so that should be part of our inclusion criteria, which it was. We also coded different types of CWB, so productive deviance and interpersonal deviance. So our productive deviance includes things like absenteeism or, you know, presenteeism, so being at work but not necessarily being completely present in the job, and interpersonal deviance would be those abuse and neglect factors. Then we aggregated those effect sizes together, so the job demands together, job resources together, and strain together, and we aggregated the quality of care effect sizes together and the CWE effect sizes together. And we converted all the effect sizes into a common correlation and reverse directed when necessary. So let's say the outcome was poor quality care instead of quality of care, we just, you know, reverse that direction to indicate we're looking at quality of care as an outcome. And also, there are some papers that reported multiple types of the one construct. And in those instances, we aggregated the data as well. So, for example, here in the study table, you can see that in Andela's paper in 2018, they looked at workload and emotional demands as two separate effect sizes to capture job demands. So where that was reported, we aggregated those effect sizes by averaging the effects, so combining those effect sizes and dividing it by 2, and then seeing how that relates to counterproductive work behaviours. However, in saying that, there are some papers that discuss not doing this, not averaging the effect sizes in this way, to reflect, you know, one effect size from one paper. So we also used a robust variance estimate, which I'll talk about shortly. So in terms of our data analysis, we used 3 packages in R: PsychMeta, RoviMeta, and Meta4. We used PsychMeta to look for the true effect size according to Hunter and Schmidt. So what that means is that it counts for measurement error and it counts for sampling error to give us the true effect once those factors are accounted for. We also use RoviMeta to look for the robust variance estimate, which does a statistical analysis to counteract any statistical issues that come from using multiple effect sizes from the one paper. And we also use Meta4 to assess our moderating variables. So we had a look at the assumptions and biases first before running our analyses, and we found, in terms of checking for the assumption of homogeneity, that unfortunately heterogeneity was quite high for our relationships, indicated by an eigenvalue of greater than 75%, and the p-value, the significant p-value for the Q statistic. So in light of this, we then conducted some moderation analyses to figure out whether or not, you know, there were some factors that were impacting heterogeneity in our data that we did not account for. So we had a look at the effect size type. So was the effect size that was reported in the paper impacting this level of heterogeneity? And we found that no, it wasn't. It didn't matter if it was an odds ratio, beta value, or correlation. We also thought, okay, well, maybe the type of job strain was impacting heterogeneity, and we also found no, that wasn't a factor. And we also looked at CWD type, and that wasn't a factor either, so non-significant. So in light of this, we concluded that it could potentially be the small sample that we had in our meta-analysis. So while we had 43 papers in total, when looking at the different subgroups, the sample size was actually smaller, and that could be potentially why. Additionally, it is quite common in organizational psychology research to have high heterogeneity in meta-analyses, purely because of the, I guess, the broadness of the variables and the type of research conducted, specifically when there is lots of variability in job demands, job resources, and we specifically were interested in the differences between the two settings more so than the individual variables. Also looked at publication bias as well, using a funnel plot, and here you can see that the effect sizes are spread across both sides of the funnel plot. They're quite scattered throughout, indicating no publication bias, but you can also see that there are potential outliers in effect here as well. But this was also accounted for with the small effect size, small sample size, that we have. Okay, this brings us to our results, our main effects. So this is the relationship between the IVs and the DVs across both settings. So what we found is that across both settings, so hospital and residential aged care settings, high job demands significantly impacted quality of care, as did low job resources, as did job strain. And you can see that the most impactful independent variable was low job resources, with a effect size of -0.41. We also found that high job demands impacted counterproductive work behaviours across both settings, but unfortunately we did not find an effect for low job resources and job strain, with the confidence intervals spanning 0. So for our meta-analysis, we did find support for our hypotheses regarding quality of care, and we only found support for the hypotheses that high job demand will impact counterproductive work behaviours with an effect size of 0.10. We also ran the robust variance estimates as well to see whether averaging the effect sizes was comparable to letting the program in R tell us the validity of those tests, and you can see that the comparisons are comparable here as well. In terms of the results of our moderation effect, we did find support for our hypotheses. So we found that the relationship between low job resources and quality of care was higher in aged care, or stronger in aged care, compared to hospital settings. And a t-test comparing these differences was significant, indicating this is a true effect. Similarly, we found that the relationship between job strain and quality of care was stronger in aged care compared to hospital settings. And again, this is supported by the t-test, indicating that these differences are significant. Unfortunately, we could not test this relationship with job demands because we didn't have enough of a comparison, enough samples in our comparison. So our Ks for aged care was like 1, I think, for job demands, compared to hospital settings. So we couldn't do a moderation analysis there. And we had a similar problem with counterproductive work behaviours, where there weren't enough studies to conduct a moderation analysis to compare differences between the two groups with confidence that those results were going to be accurate. So we can only really look at these variables and quality of care. So in light of these results, and looking at sort of the main effects, we see that high job demands and low job resources and job strain overall impact the quality of care in care settings. And that high job demands impact counterproductive work behaviours in care settings as well. So this is in line with our theorising and is supported by different job design models, and including the job design and resources model. It's also supported by the conservation of resources approach, which indicates that individuals are motivated to conserve their resources at work and will likely engage in resource gaining behaviours and resource conserving behaviours, such as, for example, withdrawing from their job to conserve their energy, conserve their resources in response to the demands that are placed on them at work. And that if there is an imbalance there, that's going to cause job strain. The finding that high job demands are impactful in, influence the onset of counterproductive work behaviours, but not job resources and not job strain was an interesting one. It wasn't what we expected, as we thought, all variables were going to be influential in influencing counterproductive work behaviours. But a further investigation into the research indicated that this is supported by a multi-level approach to counterproductive work behaviours that factors in individual, group level and organisational level factors in the onset of counterproductive work behaviours with the working population. So that is, individual factors such as social dominance orientation or hostile attributional style will likely interact with things like team processes or other broader organisational factors to facilitate the onset of the enactment of counterproductive work behaviours in response to job demands. So in terms of what impacts counterproductive work behaviours, it's definitely a multi-level approach as opposed to a single level approach in response to job demands. So in light of these findings and in line with our theorising, these findings suggest that potentially that there are differences in work characteristics between these organisational settings. So there are differences in job characteristics between residential aged care and hospital care that is impacting the strength of the relationships between low job resources and job strain on quality of care and counterproductive work behaviours. And that, so these differences are exacerbating these negative outcomes in some industries and some working units. So, for example, in residential aged care and with frontline staff. And these results provide an initial indicative support to continue ongoing further investigation and ongoing further research into the superordinate factors that are impacting these industries, such as looking at market professional logic assumptions in residential aged care and how it is impacting these outcomes. I did want to talk about the limitations as well, and I've kind of touched on them already. So the small Ks in our study meant that we weren't able to conduct moderation analyses for counterproductive work behaviours, which is really unfortunate. We also had high levels of heterogeneity, and we had less studies in residential aged care compared to hospitals, which could be impacting the strength of our results. In terms of the practical implications for care in general, in light of our findings, we can say that low job resources has direct consequences on quality of care in care settings, and that high demands also have consequences for the onset of counterproductive work behaviours in settings as well. So this this has real considerations regarding the importance of having good quality work design to mitigate these negative outcomes within care settings in general. And in terms of other considerations for regulation, particularly for residential aged care, it provides initial support for further investigation into these subordinate impacts, such as the privatisation model, on work design decisions and on other policy implications within these care settings as well. So in terms of future directions, we suggest that more research needs to be conducted on the factors influencing job design in residential aged care and in care settings in general. So, some of the questions that we have are, what are the roles of institutional logic, such as the market or profession, in creating poor employee outcomes in residential aged care? And is there a relationship between market logic and the role, the value attributed to service roles or frontline roles in residential aged care? And is this exacerbated by negative beliefs regarding the often stigmatised ageing body and hence, specific value regarding, market logic and giving back to the economic society? In terms of the direction that I'm going to take with my next 3 studies, is I'm hoping to conduct these 3 studies to answer some of those questions myself and build on this meta-analysis research. So the first one is a case study analysis where I'll be coding for themes related to institutional logics, the state of anomie, which relates to this concept of devaluation, and work stressors in residential aged care facilities during the COVID-19 outbreak in Victoria. So I'll be doing that through analysing media articles and doing a qualitative thematic analysis to sort of, again, build on these potential themes to see if there is an impact there between the market and these outcomes. Then I'll be doing an experimental study with managers. So I'll be manipulating, I'll be putting them in a simulation, manipulating the conditions where one will be they've gotten a job and they're manager at this job, and the objectives are highly marketized. So there's a high market logic prevalent within that silhouette or within that simulation, compared to another condition where there is a high care logic within that simulation, and see whether or not these logics within these 2 conditions impact the work design decisions that they make. So then they'll be asked to design a job for personal care workers, and that job role that they've created will be evaluated for how mechanistic it is in design, or how enriching, and the various job characteristics that are created within that role. And I'll also be assessing existing neoliberal beliefs as a potential moderator in this experiment. Then I'll also be doing a correlational study with frontline workers, looking at the relationships between perceptions of institutional logics and their impact on counterproductive work behaviours. And I'll be looking at whether or not the relationship between institutional logics and CWBs is mediated by feelings of anomie and devaluation, and the perceptions of their job. So whether or not their job design or their job characteristics measured under the WDQ, the work design questionnaire, mediates this relationship as well. And also hopefully doing some qualitative studies looking at this idea of devaluation for frontline service roles as well. So in summary, the meta-analysis that we conducted indicates that job resources are the most impactful on quality of care, and that job demands are the most impactful in influencing counterproductive work behaviours, and that these relationships are stronger in residential aged care for quality of care, and that future research needs to investigate the effects of these superordinate factors on work design and job characteristics, and potentially these subordinate factors could be these institutional logics that we've talked about. And that is all from me. Any questions?